Good afternoon, everyone. It's Maureen Dobbins, the Director of HealthEvidence.ca, talking to you today about preventing alcohol and marijuana use among youth. What's the evidence? This is webinar number 2 in a series that have been funded by CIHR. I'll talk a little bit more about that in a moment. So I just would like to welcome all of you today to our webinar. Unfortunately, we've run into a glitch where the number of participants without our knowledge was capped, and so several people will not be able to join us. If you are a colleague of anyone who has been unable to get in, we are informing people of the issue right now, and certainly we will look to set up an additional date in order to rehost this webinar so that the many people that wanted to be here today will be able to participate. Today's webinar is also going to be a little bit different from some of our previous ones in that I will spend the first part of the webinar talking about the findings of the review by Leenstra, published in 2010. And then in addition to that, we have a really exciting opportunity to hear from Diane Smiley, who has some firsthand experience in implementing the types of programs that have been evaluated in this review. And so we're going to hear that user experience about implementing evidence into practice from Diane, a short talk there, and then we'll use the rest of the time to entertain your questions, comments, and thoughts. I believe we've asked you to respond to 2 of the polling questions, those being what has been your experience in finding and using evidence related to substance use among youth, and then the second one, how do you use research evidence to inform your practice? So if you haven't had a chance to complete those poll questions, please do so, and we'll be asking you a couple of additional questions throughout the webinar. So just showing you here quickly the health evidence team. These webinars really are a full team effort that are either in the room here with me or also joining us virtually as well to manage all components of presenting the evidence and managing the chat. And so this is just a look of who we are here at HealthEvidence.ca if you're unfamiliar with us. Just very briefly, because I know some of you have come to many of our webinars before, but for those of you that are new, HealthEvidence.ca is really attempting to help facilitate evidence-informed public health in Canada as well as throughout the world. And it's in our thinking of being able to facilitate easier access to the evidence on the effectiveness of interventions at the review level, making it easier for professionals and decision makers to access that evidence. That makes it easier to integrate that into decision making. We've also asked you to tell us where you are from today, and while I am seeing that we have representation to a great extent from across Canada, many of you are joining us today from Ontario, but welcome to all of you that are joining us from elsewhere across the country. So just a little bit more about health evidence. So why did we create this repository to begin with? Well, we know from interacting with frontline public health decision makers for many years now that looking for effectiveness reviews in large databases is very difficult and time consuming. And so finding all of the evidence and putting them in one place saves you time. When you go to health evidence, you know that you are only going to find reviews of effectiveness that are relevant and current. We are only ever behind the published evidence by a couple of months. We try to use a very transparent process so that you would know why a review was included in health evidence, how we appraised it for methodological quality, and all of that is accessible to you on the site, as well as our tools that we use in making those assessments. As well, we also know that evidence-informed decision-making isn't only about having access to the evidence. It's about having the knowledge, skill, capacity, and a culture to incorporate research evidence into the very complex decision-making processes that you all engage in. So we also offer additional supports at Health Evidence, in the terms of tools, training, knowledge brokering services that are also there for you as a resource. And first and foremost, we're trying to make all of the tools as well as the ability to search health evidence as easy to use as possible. So today, today's webinar and this series of webinars that we will be doing throughout the remainder of the year has been funded by CIHR, the Canadian Institutes of Health Research, from the Knowledge Translation Supplement program, where we applied for funding to hold webinars to bring the content of research evidence to the frontline decision makers in public health. And the review that we're specifically focusing on by Leemstra et al. Is called the Systematic Review of School-Based Marijuana and Alcohol Prevention Programs Targeting Adolescents Aged. We also are evaluating these webinars, and so we would ask following the webinar that you just be on the lookout for an email that you will get from us. Here's the email address of who will be sending you a link to a very short survey. I promise you it will not take you longer than 5 minutes to complete. And it's very important for us at Health Evidence to receive this information, this evaluation from you, because it's how we continue to tweak and make these webinars more and more useful to frontline practitioners. So please take a moment to complete that. Okay, so let's just get into the summary now. What I'm going to propose and present to you over the next 15 minutes or so is very high-level synthesis and summary of the Leemstra review. The first thing I'd ask you in a polling question is if you've heard of Pico before, and you've started to answer that. And what we have out here on the slide that you can see is what the Pico for this particular review is. So as that's just all being, your data is being accumulated, that I can see for the most part, for more than half of you, you are not familiar with Pico, and some of you are, so wonderful for those of you who do know what Pico is really just a construct that allows us to break a research question down into specific components. And so the P looks at the population of interest that we want to know about, the intervention that we're studying, what that intervention is being compared to, for example, usual care, and the O stands for the outcomes that we're interested in. And what is really very helpful about Pico is if you are wanting to really be explicit about what your question is that you're searching the literature for, it can be very helpful before you search any database to actually fill out these Pico components. That way you will be very, very clear in your mind what you are searching for, what evidence you are searching for. It will be then easier for you to determine if your results are on track or relevant to the question that you have. Specifically for Leemstra, our population are 10 to 15-year-olds. There were 2 different interventions being compared in this review. The first one was a knowledge-only program, so it was the provision of anti-drug information in the school setting. And intervention B is a comprehensive program that includes that knowledge-only program we've labeled here as intervention A, plus additional skills around the development of skills on refusal, self-management, and social skills. And this was being compared to usual care or knowledge-only, or in some instances where there was no program at all, and that could come under the usual care. It was also studies in this review had to have an intervention that was implemented for a minimum of 1 year. And our primary outcome is long-term reduction in marijuana and alcohol use, measured as the mean usage ratio, which is the mean number of days of usage of alcohol in 30 days in the intervention group compared to the same mean usage in the control group, and that was done both for alcohol and marijuana use. And the secondary outcomes was looking at the effectiveness when you compared the knowledge only to the comprehensive program. The very last bit of information on this slide is the quality rating. So this refers to the methodological quality of how Leemstra et al. Went about doing this systematic review. And what we can see here is that they received a rating of 9 out of a possible 10 points. So this is a very well done, rigorous, systematic review in terms of the methodology that the reviewers used as they walked through the process of synthesizing the knowledge from individual studies. So we like to start these webinars with really jumping to like the back of the book and seeing what the overall findings are. And generally the overall findings suggest that comprehensive programs lead to a mean reduction of 12 days of alcohol use per month and 7 days of marijuana use per month in 10 to 15-year-olds. What we would also add here is that for knowledge-only programs, there was a mean reduction of 2 days of alcohol use per month, although that finding was not statistically significant, and I'll talk a bit more about that momentarily. And that from the results of one study, where then multiple studies were not pooled, one study included in this review that evaluated a knowledge-only program on marijuana use saw a mean reduction of 25 days of marijuana use per month in this same age group, 10 to 15 years. However, it's important to also point out that additional analysis was not conducted in these primary studies that looked to see whether or not there were differences in effect of these interventions by age, gender, socioeconomic status. Various other factors there weren't taken into consideration. So we're only able to say overall, amongst the sample included in each of these studies, which in total was over 11,000 participants, overall these are the general results. We think about what the implications are for practice, and I also think that this is a first stab at these implications, and certainly following our discussion today, perhaps we might want to rethink these a little bit, but generally at this point, the evidence would suggest that public health should promote, support, and or implement school-based programs, comprehensive programs that provide children with the opportunity to practice those refusal skills. As well, the program should be implemented for a minimum of 1 year, and that perhaps there's evidence to also suggest that the knowledge-only programs could still be provided if if providing comprehensive program is really not possible to do. And I'm just going to comment, if we just go back the one slide, Heather. The last point we say there about public health should not promote the knowledge-only programs to reduce marijuana use. That finding, and actually we should discuss this further. I'm happy to hear your thoughts on that, wanting to hear your thoughts on that. Definitely, because there was only one study that evaluated marijuana use from the knowledge-only program and therefore wasn't pooled with any other data, this really was not highlighted in the large effect size was not highlighted in the abstract of the review of this systematic review, of this meta-analysis. And so that was, we included that at this point, but I think given the very large effect size, even though it is from one study, we should have some discussion a little bit later on about, yes, I agree with you, and I was just talking about that. That's what I was just discussing there, and we will come back and discuss that further a little bit later on. Okay. For those of you that haven't had a chance to look at the actual data that's included in the review, this is one of the data tables. And really, I just wanted the opportunity to just break down this table a little bit for you, because sometimes tables that have this type of quantitative data can be actually a little bit intimidating to look at. So really all we have down the first column are our studies, each of the studies, the year they were published, and when they evaluated the outcome. Then in the second column, which at the top of the header has the MUR, so that's the mean usage ratio, gives us our numbers we see at the top there, 0.88. So a number of 1 would mean that there was no difference in the mean number of days of alcohol usage in the past 30 days in the intervention group compared to the control group. And any number below 0.1 represents less days of, for example, alcohol consumption in the intervention to the control group, and a number above 1 would mean that the intervention group had actually had greater number of days of usage in comparison to the control group. So a positive finding with respect to the intervention, whether it's knowledge only or the comprehensive, is that the numbers would be below 1. The next column that we see here, the header at the top says 95% confidence interval, and then we see a range there. So right beside the point, the 0.88, we see a number of 0.87 to 0.89. Sorry, I know those numbers are likely looking a bit small for you. And so basically what we're doing here is it's always very important to consider the confidence interval. While the MUR, the mean usage ratio, of this meta-analysis is giving us that one overall effect size, the real story is the range of effect. And so the 95% confidence interval tells us that if we were to replicate this review 100 times, the true effect would lie 95 times out of 100 between a certain range. And that's the range here, which is very, very narrow. 0.87 to 0.89. That's between 11 to 13 days. So the true answer that would exist for the whole population is somewhere between 11 to 13 days. Why it's really important is to look at the confidence interval is if the confidence interval was very wide. Let's say, for example, the confidence interval here ranged from half a day, or even let's round it and say 1 day to 25 days less usage. Then the way we would interpret that is that there is an equal chance that the real answer, the reduced consumption, lies anywhere between 1 day and 25 days. So if we implement a program, we have to be prepared that our real answer, our real effect, will be somewhere between 1 and 25 days. There's an equal chance that the answer is any one of those options between 1 and 25. So that's why a confidence interval is very, very important for us to think about. And so we just have a poll open right now that asks if you were familiar with mean usage ratio and how this is calculated and what it means. And you're responding to that right now. And it's actually very similar. About a little over half of you are saying you were not familiar with that. And a very nice percentage of you are saying that you were, which is great to see. So the other, sorry, just go back for a moment. And then the other thing I just wanted to point out to you in the fourth column is relative weight. And we see again, if we keep going across that top row, 0.07. And again, what this is telling you here is the amount of weight that that study had in the overall finding. So usually when we do meta-analysis, the largest studies will end up having the greatest weight in the overall answer that we find. But very important when you actually see the results of meta-analyses to scan what the weighting was. And certainly as it pertains to this particular review, we'll talk briefly in a moment about this, there were some studies here that actually really made up most of the weight of the answer. And so we'll talk a little bit more about what that means shortly. So if we just move on in terms of what is the evidence now, so what are we basing our overall conclusions on? We see that for comprehensive programs that include skill building activities for children, we saw a mean absolute reduction of 7 days per month, which is the 0.93. If you took that up to 1, that's 0.7, so that's our 7 days per month, with the confidence interval ranging between 0.92 and 0.94. So between 8 and 6 days per month is what our reduction is. And then when we look at that for alcohol use, the mean absolute reduction is 12 days per month, which we see there as the 0.88 with a range of 0.81 to 0.89. So the range being 19 to 11 days per month for the comprehensive program. Now, I just want to point out again, because this is actually, I'm not going to say a complex review, but it's also why it's very important as consumers of these types of reviews that we both read tables and we read the text. So what we've included here for you, which is the table that's included in the review, we see some different numbers here from the ones that I was just reporting to you. So if you read across the first row, we have a pooled estimate with no stratification. And this is based on the comprehensive-based studies, of which there were 3. But when we looked at both, when they looked at both alcohol and marijuana use together, we see a mean usage ratio of 0.91 that ranges from 0.88 to 0.95. And then going down below that, we then see, they then look at it by alcohol, and then they look at it by marijuana. And then they did some additional analyses there as well. To some extent, what happened in this review is some findings were only ever written in the text, and some were included in the table. So that's why it's important to be looking at both of those. One of the things that's also important to point out here with respect to the comprehensive program is that we will see, Heather is going to help me here, but if we read across the row of Botson et al. 2001, the finding of that study was 0.88 mean usage ratio, so that's the 12-day reduction, ranging from 0.87 to 0.89. And if we keep going to the next number, 0.96, that is telling us what the relative weight is. What is the contribution of this one study to the overall finding? And we can see that this one study is influencing almost completely the overall finding. And in fact, the pooled risk ratio that's reported in the text is the exact same as that reported for Botson. So the 12-day reduction with a range from 0.87 to 0.89. So just something to be aware of with that one. Okay, and if we just move on. So the implications is that for comprehensive programs is that we would want to be promoting and supporting long-term comprehensive programs to reduce both alcohol and marijuana use. Certainly, what we can say from this review is long-term constitutes interventions implemented for 1 year, and that this should include the development of life skills, refusal skills, and self-management skills in that implementation program. And that comprehensive programming was preferable to the knowledge-only programs for, I would say, alcohol use. And I think that we could debate the marijuana use. I think it was defaulted because there was only one study included, that wasn't, that was seen as very limited evidence, but certainly I think it would be great to hear your thoughts on that as we go through the webinar today. If we look at the knowledge-only programs, and again, this is where we've picked this out and wanted to include this because we're not, we just wanted you to be aware of what all of the evidence was in this review. So from one single study that looked at a knowledge-only program included in this review that looked at marijuana use, there was a mean usage ratio reduction of 25 days, ranging from, now I'm on the spot for doing some math, 37 days to 13 days. The issue here, and of course we only had one study so you can't pool it. The issue here, I guess, is what is the threshold that each of you brings to the table in terms of what constitutes enough evidence upon which to act. So for some of you, this will be very compelling, influential evidence that would strongly suggest knowledge-only programs are effective in reducing marijuana use. And for others of you, one study might not be enough evidence, and you might decide that you want to hold off until there's additional studies that could then be pooled. Or even following it one step further, taking a very close look at that single study and seeing who the audience was that participated in that. Is it very similar to the audience or target audience that you are providing services for, and then making decisions accordingly. We're just presenting the data here and not wanting to influence what those thresholds are for you. And then also what we saw for alcohol use is while overall we see our MUR here, our mean usage ratio is 0.98, which is a 2-day reduction in alcohol use per month. We can see here that because the 95% confidence interval crosses 1, which would be the line of no difference, which means the intervention group was no better off than the control group. So because our confidence interval ranges from 0.92 to 1.04, even though there's a 2-day reduction, this finding is not statistically significant, which really then tells us that this intervention was not effective, despite its overall finding showing a 2-day reduction. So what are the implications? Oh, sorry, I'm moving on too quickly here. Again, when we look at the 3 knowledge-based studies and they're pooled all together, we see overall for alcohol and marijuana together a 0.96, so 4-day reduction. But again, the confidence interval crosses 1, and we don't see a statistically significant finding. It goes from 0.89 to 1.02. It is important, I think, and was very important for Leemstra et al. To then do further sub-analysis by alcohol and marijuana. We can see here that if they had only ever pooled alcohol and marijuana together and didn't break that down, that there's actually, there could be differences in the impacts on alcohol or marijuana, as we did see in the comprehensive-based program. So important that they did that here. Again here just showing you overall what happened when they pulled it together. And then if you look at the bottom of the slide, that's where we see the one study conducted in 2005 that shows that fairly large statistically significant reduction in marijuana use coming from the one study. We can also see, if we go over to the far right-hand column, that there were 650 participants in this study. So compared to some of the other, or certainly the Shop et al. Study that looked at, that was only for alcohol, the Wirch study is much smaller study. So implications for policy and practice here, one could say that the evidence supports shifting existing knowledge-only programs to long-term comprehensive programs to have a better impact on reducing alcohol use, and that these programs should include skill development focus to reduce both alcohol and marijuana use. So if we just go back to the overall findings in terms of the evidence, is that we do see then the comprehensive program resulting in a mean reduction of 12 days of alcohol use per month and 7 days of marijuana use per month among 10 to 15-year-olds. That for the knowledge-only program, the mean reduction of 2 days per month for alcohol use is not statistically significant. And what I will add to this PowerPoint following today's presentation is that from one study, we do see a fairly large effect on marijuana use of 25 less days of marijuana use per month. But again, we need to be careful, given that they haven't looked to see if there's any different effects by various variables as age, gender, or socioeconomic status. If you are implementing these programs, I think it is very important to consider doing additional evaluation by those different types of groups and see if there are different effects happening. So again, just recapping that their evidence does support ongoing school-based programs, these comprehensive programs that include skill-building activities. They'd be a minimum of 1 year, and to some extent, knowledge-only programs not quite so positive for alcohol use, although some very limited evidence on marijuana use. So I'm I would just like to actually, before we go to questions, I think I would now like to introduce Diane Smiley. Diane Smiley has many, many years experience working in the addictions field and has been working with a group called Connections Canada, where we have been evaluating or really pilot testing a knowledge brokering intervention with addiction agencies across Canada providing services to women with addictions. And Diane is just going to give us some first-hand experience about implementing these types of programs in practice. So Diane, welcome, and we'll hand it over to you.
Thanks, Maureen, and it's great to be here, and I'm very happy to try and stimulate a little bit more discussion and thinking by sharing some key elements of my own experience working in partnership with a number of people to implement a comprehensive, longer-term, interactive, school-based prevention intervention a number of years ago. And so I'll just kind of launch into some of the things that I thought were useful, because you know, it's obviously, you know, you've got the evidence, and it's really critical to consider that carefully. But when, you know, it hits the road, there's a number of other things that people need to take into account as they think through what's the context. So one of the big things that we had to think about right off the bat was, you know, working really in partnership with the school system and you know, different levels of the school system to think about implementation. We needed to be working very closely with key stakeholders that included senior school board and school officials from the social work department. Also needed and the boards of education that were involved, school principals. We needed these folks to help provide some leadership within the schools. You know, various approvals that were needed, and really just to, you know, lead the whole navigation of this implementation process. We also really needed and valued the involvement of teachers at an advisory committee level, sort of as we were working on this, that they were the ones that really had some great insight into what was happening in the school classroom setting, and what was, you know, what we would need to think about in terms of how it would be implemented. And then, of course, we also needed to have the involvement of students to help us figure out things like recruitment and help us understand, you know, how would we deliver this in a way that would, you know, best engage and appeal to their peers. So through that kind of a process, we realized that the ideal of doing something long-term and interactive, and, you know, with a skill-based or skill development focus, would take a lot of classroom time. And this, you know, is something that we need to really think carefully about, because as everyone probably knows, there's already, you know, core curriculum that needs to be delivered within the classroom setting. So we had to spend a lot of time thinking about, okay, well, how would that work then? If we're going to, you know, you could understand in some ways why previously people had kind of moved towards more knowledge-only and sort of shorter-term types of programming that could fit more easily kind of into what they were doing in their health curriculum already. So, you know, in trying to think this through, we thought, okay, well, what about outside the classroom? But then, of course, we had to think about, well, that, you know, more challenging in terms of that. So that was, you know, another important key thing that needed to be thought about. And in the end, in this particular example, we ended up doing something that was sort of a combination of inside and outside of classroom time because of some of these contextual considerations. And then I guess the last, you know, sort of key area that I want to just touch on is how important it is to know the particular population that you're going to be working with. And in this case, it was a program for pregnant and parenting young moms that were in high school and who and so we need to really think carefully about how, how did that shape our, the implementation as well. So things like, how would childcare work for these young moms who are participating? If it was in the classroom, then many of the children were already in daycare, and that would have worked well. However, at the same time, these young moms were juggling quite a bit and trying, to also make sure they got into school often enough to be able to learn and achieve what they were hoping for academically. So that was another thing we had to think about. We had to, when we were offering some of the programming outside of school hours, fairly anticipate as well, because many of the young moms were attending school that was outside of their own neighborhood, so we're needing to travel quite a bit. So anyways, these I think are some of the examples of some of the things that need to be thought about, and that how the context really does shape the implementation process.
Thank you very much, Diane. That was very helpful, very informative. And I would now like to open it up to some additional questions or comments that those of you on the line might have. I can start with, there's one that I will answer, and Diane, I think you might need to turn off your mic. Sorry, we've turned your mic off, so now we've gotten rid of the feedback. I'm going to start with trying my best to address one question, and then we actually, Diane, have forwarded one on to you as well that I'd like to get your perspective on. So the question raised was, if you can just take me back there, Heather, in my experience in doing interviews with younger people, they only drink on the weekends and then only occasionally both Friday and Saturday. Not sure how the average student could have a 12-day reduction per month. Excellent comment, Lee. And I guess what's really important to point out here, I didn't mention this before, I believe all of these studies were conducted in the U.S., in fairly large urban areas. And so the first that we could look at here as a potential issue is that the participants in these studies are quite different from the students that you've interacted with in the past. In terms of their usage is much higher than perhaps what different age groups are seeing here. So the first thing that this gives rise to then is when we think about, are these results applicable to the population that we are serving, or the different populations that we serve? So certainly, and again, this is the average use. So there could be some participants in these studies that actually have daily alcohol consumption, and then there might be others that have very little alcohol consumption. But when they average it out across all of the participants in these studies, in comparing the mean number of days of usage in the past 30 days in the intervention group to the control group, that was the number that they came. The other comment, and Diane, I think we're going to turn your mic back on, was, and I'm just going to read it here for everyone, and then we'll let you speak, Diane, as it says, wondering if people are trying to recreate programs that are already in existence to fit with what appears to be best practice of comprehensive programs. So we're just going to let you open up your mic, Diane.
Hi. I don't know if people are trying to recreate programs. Yeah, actually, I don't. In this case that I was involved in, and some others that I'm aware of, this was through the youth drug strategy funding a number of years ago. People were actually developing and piloting programs that were based on the evidence at that time.
Okay, and we'll just turn off your mic, Diane. Thanks for that comment. And it is a really important question that is being raised, because I think certainly in other areas we've seen, a study comes out that evaluates what's been labeled as a comprehensive program, and then when others implement that and additional studies, they might not necessarily implement the whole program. So there might be bits and pieces of a comprehensive program that melds better with that situation or that setting that are implemented, or there aren't the resources to do the whole program. And so you know, based on knowledge I have in other areas, I would guess that there is a, you know, probably a fair amount of differences across the country in what would constitute a comprehensive program and how those are being implemented. It also, it's what makes it very complicated about doing a meta-analysis as was done here if those programs that are being evaluated and then synthesized are actually different. And we certainly have seen that in another meta-analysis by Nichols et al. That looked at integrated substance abuse programs for women with children with addictions versus non-integrated, where the many studies included in that review, the integrated programs varied quite differently from study to study. And so it is an important issue for us to be thinking about. So we have an additional question here that asks, did the results give clues on the impact of booster sessions to regular programs? So thank you. That's also a really good question. I will, unfortunately, I would say that the best answer I can give you from the review is that the review didn't really that didn't come out loud and clear in the review. Now that's not necessarily a downside of the review itself, of this particular review or these review authors. It's one of the downsides of doing meta-analyses, doing systematic reviews, that in synthesizing multiple studies about an intervention, we actually lose our ability to really say a lot about what all comprised the intervention. So in my reading of the review, and I'm having someone else quickly look at the review right now, I do not believe that we certainly, if others have read the review or have different comments on that, we'd be happy to hear them. So, sorry, we're just seeing here from Lindsay McRae, who is also part of our staff, who looked at these, said that half of the included studies used booster sessions, but there's nothing specifically brought out in any of the meta-analyses that actually are telling us specifically about those booster sessions. All we can say is that in its entirety, the intervention that also included booster sessions were included in this review, but nothing's been pulled out specifically on their impact. So we asked you a couple of additional questions, and the first one was, did you find the data in the review helpful? And a great majority of you have said yes. And then we also asked, were these findings new to you today? And there we're actually fairly close in terms of just a few more of you saying yes, they were new, and others saying they weren't new. Definitely for those of you for whom this is not new, I actually see that as a positive sign and that you were already aware of these findings. This is perhaps just reiterating knowledge that you already had, whether you knew it from this review or elsewhere. It's just additional justification. So we have an additional question here that says, and so just bear with me as I read these. I'm reading them for the first time as I say them, so sometimes I need a couple of seconds to also think about my answer to the question. So a 25 mean usage ratio with a knowledge-only intervention regarding marijuana use with question mark. I do not understand how much marijuana use there would have been per month per intervention. So again, this is very similar to the question that Lee raised at the very beginning. I mean, in essence, this implies that on average, students participating in these studies would have had almost a daily usage of marijuana use in a month, and that the results are illustrating a reduction of 25 days per month. So what this allows me to think about here is, one, we might question that. Does that seem very different? Again, as I was saying earlier, is this very, very different from what you know to be true of the populations that you serve? So it might suggest that this is a very high-risk group for whom these results are applicable to, and would they work the same for students whose usage rates are much lower? So that's a question that we can ask ourselves. Something else that this also brings me to, in terms of more from a research side of things, and why it's important to be cautious when we have the results of just one study. is if we were to see a positive result from a randomized control trial in the first time a randomized control trial was done, you know, we're very happy about seeing those results. But what we know over time is as that trial gets replicated, the next time we will likely see less impact. The next trial will see less impact. The next trial will see less impact. So at some point, we usually see what we call more of a regression toward the mean. And we do know in other areas of healthcare that 2, 3, 4 trials down the road, replication trials, we actually no longer see that statistically significant impact, or in this case, a reduction in use. So this is a phenomenon that happens throughout the scientific literature. It doesn't always happen, but it is known to happen, and it's why I think we need to proceed cautiously in terms of our interpretation of this one study. As I said, for some of you, this might be the evidence that you are looking for to justify a particular program with respect to knowledge only, and for others it wouldn't be enough to move to that or to replace from not doing a more comprehensive program. So an additional question here from Lee is there a specific comprehensive program that is considered best practice in relation to what you're describing? So again, Diane, I'm actually going to pass this over to you first, and then once you've had a chance to comment, then we'll take it from there. So just opening up your mic, Diane.
Thanks, Maureen. And I'm sorry, which question is it? We're at.
We might not have sent it to you. I'll just read it out to you again. And the question is there a specific comprehensive program that is considered best practice in relation to what we're describing here?
Again, in terms of a school-based program, I can't say that I know for sure that there is one that, I think there's a number that are comprehensive, and that there has been, you know, sort of more at program evaluation level done. And I'm also wouldn't necessarily say that, you know, I'm currently up on what would be the most, what is evidence-based. So sorry, I'm probably not being that helpful in answering that question right now. I know that you know, I think people are aware of strengthening families. There was, which is, but that's
okay,
outside of school programming. And maybe there's other people actually that
okay,
might be aware.
Thanks, Diane. We're just going to mute you again, and I know I'm putting you on the spot as well, so sorry for that. Bear with me. What I can say, Lee, as well, directly to your question is, we would not be able to say from this review that a specific comprehensive program is the one that is being recommended. Just that I mean, I can answer that and try to answer this in two ways. Generally, the intervention, the comprehensive program that was evaluated in this review, it was school-based, it lasted for a year, and in addition to providing knowledge around, for example, impact of alcohol use and marijuana use and trying to promote reduction in use, the comprehensive program also provided those additional life skills, refusal skills, for example. Without going to the individual studies and looking at them much more closely, that's what the result is saying, is that this overall comprehensive program led to reduction. However, what I was alluding to before that's important to look at in terms of the meta-analysis results here is that by and large, even for the comprehensive program, the findings are being very, very highly influenced from one study. And that's the study done by Botvin in 2001. Whereas the other two studies under the comprehensive-based program end up having very, very little weight in the overall finding that is reported in this review. And so what one can really surmise from this is that it's really the intervention that's been evaluated in Botvin, and then getting that Botvin study and looking into that one much more closely, that would give you a better sense of what those findings are. It's important to point out here that in trying to be as unbiased as possible, is that there's also an extreme limited evidence for the comprehensive-based studies from this meta-analysis. While there were 3 studies included in this on for alcohol and then 2 for marijuana use for the comprehensive-based program, on their own, that's still not an awful lot of data, 3 studies and 2 studies. But at the end of when we look at those meta-analysis results, really the results are being highly, highly influenced by only 1 study in each of those for both alcohol and marijuana. So whether it's the knowledge-based program or the comprehensive-based program, we still have a very limited amount of evidence. So an additional question here from the Dean that says, how can a knowledge-only, i.e. pamphlet intervention, work with the group you are describing, i.e. high usage per month? They read a pamphlet, for instance, and reduce usage that dramatically, question mark. I want to know that group of adolescents. Yes, I agree, and I'm not sure that we would say that the knowledge-only program or intervention is only a pamphlet. And I'm just having someone look into that right now to get a little bit more detail about what exactly that meant. But I don't think that we should assume that it only meant a pamphlet. That it could constitute something more, keeping in mind this is an intervention that was implemented over a 12-month period, and so I'm not really sure that the provision of a pamphlet really would constitute a 12-month intervention. So I would agree that one might question what that impact really could be. However, this is the finding that this one fairly well done single study found. So coming back to another question says that also with the comprehensive programs, with those drastic reductions with alcohol use and the drastic reduction in marijuana use in the knowledge-only program, were there other significant programs within the school that may be influencing the students? I'm really, really happy to have so many wonderful questions, and obviously you're giving all of this a lot of thought because, and these are all of the kinds of critical consumer type of questions that I would encourage you to always be asking when you're reading any kind of research evidence, whether it conflicts with your philosophy of what you think to be what works or doesn't work, or if it doesn't. We need to be as equally critical of the methods of all of the studies. And I don't believe that we know that from the review. I did not recall reading anywhere in the review that mentioned we would refer to this as a co-intervention. Was there anything else happening in the schools that might have also contributed to the change in the outcome? And that is certainly not something that I recall seeing, or that is quickly. We're looking at some of the data tables from the review that talks about each of the studies, and we're certainly not seeing anything jump out at us. But certainly that's an excellent question to be asking. And again, it might require looking at some of those individual studies. Certainly, we might be thinking that if this is a higher risk group or a very high risk usage group, that maybe there are multiple types of interventions, maybe not even so much just at the school, but also going on in the community. So an additional question here that says, this research studied reduction in use. How does this transfer to prevention of use? And that, again, excellent question. And I don't, really, we can only say that these interventions were associated with reduced use of alcohol in some instances for the comprehensive and marijuana use. We would not be able to say in this instance, extrapolate this data out, the findings of this review, to say that it is preventing, let's say, students from starting to use. And in fact, that wasn't the purpose of this review. This review was to look at whether or not interventions were effective in reducing use. If we were interested, or the question that we wanted to answer was, can we prevent initiation of use? That's a different question. We would search for different studies. So we would set up a search strategy to find primary studies that were answering that question. Now, it might be that some of these same studies did measure that, but that was not the outcome that this review was reporting on, and so then they didn't pull that out. So there could be a little bit of overlap there with those studies, but it wasn't the purpose, and nor should we hypothesize out that these interventions would also be useful for prevention. And I think the next question as well, that was the next comment, was a questioning that, are we preventing use or reducing use? And so certainly here, this is among users, and we're talking about reducing. So I'm not seeing any other questions or comments being posted. So I'll just put one more call out there if you have any last-minute comments. I might just send the mic back over to you one more time, Diane, to see if you have any final comments. So we just open your mic.
No, I don't have any more comments, Maureen, but I love the questions, and I just really hope that this has been helpful for people in thinking about you know, how the evidence can inform their practice and decision making.
Thanks, Diane. Thanks, Diane. We'll mute your mic again. So I would just like to thank all of you for joining us today. It's certainly been a pleasure for me to have the opportunity to look more closely at this review and to synthesize this evidence. I am going to tweak the PowerPoint before we post that to the discussion board to reflect a little bit more of the discussions that we've had today, certainly around the inclusion of the findings from the one study. I just want to remind all of you that if you would like to hear the audio of this, we have been taping it. You will be able to see that, as well as to access the summary statement of this review that's been written, as well as the PowerPoint, are all available at the posting board. As well as all of the question and answers that came up today will also be posted there. So certainly if you want to go back and take a look, or if you want to encourage any of your colleagues to go take a look, it will all be posted there. And all you would need to do is to actually be a registered user of health evidence, which is a very, very easy thing to do. We just ask for a few demographic pieces of information, and you would get a username and password. That's all you need to be able to access that. And then I also just want to remind you about the evaluation. We'd love to hear your thoughts. I'm as disappointed as everyone who wasn't able to be on the call today that we've had this glitch. So certainly, if you have other colleagues that weren't able to be on the call today, please let them know that we will be posting an alternate date to revisit this webinar. So thank you very much. I look forward to seeing your evaluation, and hopefully you will join us in the future for additional webinars as we move on to new topics in the fall. And certainly we would love to have your feedback if there is an issue that is really, really important to you that you would like to see us consider for one of our webinar topics. We would be more than happy to hear your thoughts and do our best to accommodate those into the future.